Welcome back to the Mom and Mind podcast. I'm your host, Dr. Kat. On this episode, I'm honored to have two guests on. We are going to be talking about how to recognize early signs and symptoms of postpartum depression, understand some of the maternal health disparities, and look a little bit closer at postpartum depression and also how untreated postpartum depression can have long-term and generational consequences. My guests today are Dr. Ewurana Sackey and Dr. Rachel Dalthorp. Born and raised in Toronto, Dr. Sackey attended the University of Pennsylvania Medical School, and where she did her general adult psychiatry residency, and she served as the chief resident in her fourth year. She completed her child and adolescent fellowship program at UCLA. Her interests include reproductive psychiatry, perinatal psychiatry, maternal infant mental health, and child and adolescent psychiatry. And she has received numerous awards, including the APA SAMHSA Fellowship Award, American Psychoanalytic Association Fellowship Award, and many more. She's also a certified facilitator for Circle of Security Parenting Program and has completed many courses with Postpartum Support International. Dr. Rachel Dalthorp is a psychiatrist and executive medical director for LifeStance Health. And since 2014, she's focused on caring for women with hormone-related mood and anxiety disorders across the reproductive lifespan. Perinatal psychiatry is a large part of that work. In 2018, she worked with like-minded colleagues across the country to create a nonprofit called ISRP to support advocacy, education, and collaboration in the field. And she will also be addressing stigma, the power of support in our support systems, and having access to care, along with the importance of screening and advocacy in perinatal work. So let's meet Dr. Dalthorp and Dr. Sackey. Welcome, Dr. Sackey and Dr. Dalthorp.
Thank you. It's great to be here. Thanks for having us.
Thank you very much.
I'm very excited to have you both on. Every once in a while, I get to have two guests on and talk at the same time to two different people, which I just think really invites a cool depth to our conversation because, like we all have our life experiences, but certainly your professional experiences. And what we're going to be talking about today is something that we really need to be discussing in general. So I'd love to start with you, Dr. Sackey. How did you get into this specialty?
It's kind of interesting because I tend to do things, work backwards to like, okay, here's where we are, but then like, what were the origins of this? So I was a teacher, and from being a teacher in New Orleans, I became really interested in how trauma impacts kids, their entire lives. This was post Katrina, but 2 years after it. And so I decided to go back to med school, thought I was interested in pediatrics, became interested in psychiatry. And I was like, I want to be a child psychiatrist to help the kids that I worked with because they didn't have enough in that area.
Sure.
And through child psychiatry, I actually discovered perinatal and reproductive psychiatry. I had a lot of kids where I was like, what's going on? Are there ways that we could have prevented or minimized some of their symptoms? And then when you kind of do a history, you get their history, you get their parents' history. So many of my kids had moms who had postpartum depression or anxiety that was not treated. And so my mentor taught me about Circle of Security. I started working the IOP at the perinatal IOP at UCLA.
Okay.
And I did Circle of Security there, and I was like, I love this work. It feels like family work, and it feels like an early intervention for a lot of the kids I was working with.
Definitely. Yeah, thank you for that. It's beautiful. Dr. Dalthorp, how about you?
Yeah, well, like Dr. Sackey, I took a non-traditional path to becoming a physician. So I actually worked in hospital administration before deciding to go back to school. I started medical school when my youngest son started first grade. So it was an experience for sure. Thought I was going to be an oncologist and soon realized, no, that I want to see people get better. And when I was a fourth year medical student, I just loved women's health, but I love neurology and I love psychiatry. And so I thought I'm going to do women's mental health and really focus on that. And at the time, this was, 2013. Reproductive psychiatry wasn't as prominent. There wasn't a reproductive psychiatry curriculum for residency. So I really had to make my own path during residency training, but started a private practice in 2014 called Balance Women's Health. And we focused on treating women across the reproductive lifespan with hormone related mood disorders. So starting, with PMDD through the perinatal period and then all the way on through perimenopause. And I just love it. There's such a need for women specific mental health services. And so it was a successful practice. And in 2020, I actually joined a national behavioral health company. And one of the reasons that I did that is that they gave me an opportunity to really expand knowledge and access. We're in 33 states and have a very large number of clinicians. I think it's nearly 7,000. So a great opportunity to educate and advocate in the field. And yeah, I'm happy to be here and talk with both of you about perinatal mental health.
Thank you both. I just find it so fascinating within this specialty. Most of us, and you can speak to this for yourself, didn't know this was a thing or a specialty before we knew, if you know what I mean. You find out about it. It's along the way, either by personal experience or, like working with people who need a specific type of care, which I think really also parallels that why it's so needed. The parents and families that we all support often don't know what's going on for them, are surprised by it, and then find out about it along the way. It's quite upsetting and shocking and life disrupting and all of those things. Are you both finding that as well? Is that paralleled in your practices, that people are coming and not really knowing what's going on? Dr. Sackey.
Yeah, that's very true. So I similarly found myself drawn in residency to the cases where we had people in the inpatient unit who were in mania or experiencing psychosis, and they were either pregnant or new mothers. And it was like, how do we allow them to be sick and mothers simultaneously? Because there are so many ways in which society tells people, like, if you're sick, keep it quiet, keep it away, stay away from your kids. Kids are separated from their mothers. And we've just seen the long-term effects of that and how it's not good for mom or baby or family. And so I think because of that stigma, things aren't talked about, people don't know about things. We recently had a maternal wellness event in our clinic where we had different things such as like yoga and sound baths, healthy cooking, and then I was doing a session on what causes PMADs. What are the generational causes? What are the hormonal causes? What in your history makes you at greater risk for it? And patients were there taking notes and they were like, we never knew about this. Like, no one ever explained this to us. And the fact that postpartum depression is the number one complication of pregnancy, people do not know that. And so I think it's really on us as providers to like get that information out there because people want the information, but they don't know it. And so a lot of them are siloed in silence, isolated, not knowing things. And then that also means that their family members don't know things and don't know how to help them either.
Absolutely. Dr. Dalthorp, are you seeing a lot of that stigma in the clinic and practice as well?
100%. It is there. I think it's slowly getting better. We're recognizing just because it's such an acute problem here in the United States that there's an increasing awareness. But one of the best things that I can do for a patient is help her understand the biology behind what she's experiencing. And I think that's the best way to decrease stigma is to just bring them into the science. And so even if you think about hormones, it's not just hormones. It's not just ovarian hormones, it's stress hormones. And if you can explain it in a way that helps a mom understand that this is, a brain that is sensitive to hormonal fluctuations, but also responding to stress, and that there are genetic components and there are environmental components that play a role, that it's not your fault, right? In mental health, we tend to, not we, but outside of mental health, we blame patients, right? We say, if you just try harder or just give it some time, we might dismiss them. It's going to get better. This is normal. And all of those things kind of keep a mom out of treatment. And so when you're able to say, no, this isn't your fault, this is biology, and even the stress that you're experiencing has a biological impact on you and your mood and your anxiety, it really helps them to embrace that and they don't feel as stigmatized. I think that really opens the door for them to be willing to get help. And even with psychotherapy, it's not just medications, right? So we know psychotherapy has a biological impact in the brain, that we have increased levels of brain-derived neurotrophic factor that we can help a mom recover through psychotherapy. And so I think it's just a way to help a mom understand and be more open to getting help.
Right. Right. So obviously, yeah, it's really challenging for the person who's going through it to know what's going on. Sometimes their partners or family members might notice some changes, but they might not also have any idea of what's going on. Dr. Sackey, what are some like early signs or things that people would recognize if they themselves are dealing with a perinatal mental health disorder?
A great question. And I think across many different perinatal mental health issues, there are certain symptoms that are common. So if someone's becoming more isolative, there's more irritability, um, there's difficulty in caring for themselves and for the baby.
Mm.
There are changes in their relationships with others. I know sometimes when people have new babies, they want to kind of they're in a bubble for a bit. They're caring for themselves, recuperating, but also they don't really want to connect with people that they used to connect with.
Mhm.
There's low mood. There are people saying things such as, "This baby would be better off without me. Someone else should be the mom." Questioning, "Is this really my baby?" Um, and then more severe kind of, are they having thoughts of suicide, harming themselves, harming the baby? So those are things that are concerning, and really, we do have a lot of people call our clinic, like parents,
Mhm.
spouses, saying, "This is what my partner is going through. Can you please help?" And so I think that, again, this is family psychiatry or family psychology, family mental health, because it does impact the entire family, and families often the first line that is providing supports for our patients.
Yeah, absolutely. And like all of the symptoms you were describing are part of what keep people silent too. You know, they might not be recognizing the symptoms themselves, or they could be recognizing it, but the stigma is very silencing. So how I mean, you talked a little bit before, Dr. Dalthorp, about explaining the science. Is that strategy also useful for partners? Is it helpful for family members to understand some of those symptoms that Dr. Sackey was talking about?
Yeah, I think it is, but I think we have to dispel some of the myths that are out there. I think a lot of women, if they've never had depression, they think, well, that means I'm not going to get postpartum depression. But there's actually a lot of women who experience their first episode of depression in the postpartum period, and so we need to be thinking about this during pregnancy. We need to be proactively educating and screening and planning for the postpartum period. So I think partners are a really big part of that. They have birth classes. I know mental health might be touched on a little bit, but we really need to do a good job of planning for the postpartum period. How am I going to maintain my mental wellness? How am I going to get support? A lot of women we mentioned may not feel comfortable asking for it. And so educating those partners, don't take time to listen. Don't be judgmental. Ask her how you can help. Don't wait for her to ask you to help.
Right.
Really have a plan before you even deliver the baby, just to maintain, appropriate sleep and self care and time for mom. I think those are all really helpful things to maybe prevent postpartum depression, but also support a mom if she's having baby blues or she's having a mild depression. Of course, if it is moderate or severe, any of those things that Dr. Sackey talked about, suicidal, severe depression, can't take its care of self or baby, it's really time to have a partner advocate for that mom if she's not able to advocate for herself, and get her into treatment, because we know the risks to the baby are very high in the family if she doesn't get treatment.
Sure. And Dr. Saki, can you speak to the disparities with those, some of those, the numbers of um, women of color dealing with perinatal mental health at a higher percentage rate and some of the reasons why?
Absolutely. So studies have shown that Indigenous, Black, Asian, Latinx women are more likely to have perinatal mood and anxiety disorders, and are less likely to be detected or to receive treatment. And so there's this huge gap that we have. Studies have also shown that when these women go for treatment, they are less likely to be put on an SSRI and less likely to have follow up as well. And so then this creates, just snowballs and impacts. I often think of, like, down the line, what's that looking like for this person's trajectory in life, mental health wise, but also for their kids as well. So, number one reason medical discrimination and medical racism, a lot of people frame it in terms of, well, these people aren't doing X, Y, and Z. And they have a history of experiencing racism throughout their lives, and then also in the medical system,
Right.
which mirrors our overall society. There is also distrust because of the experiences that they've had in the past. And so I've had a lot of moms of color say, when I fill out the EPDS, which is the screener for postpartum depression, I don't always answer correctly because what's on the other side of that?
Right.
Someone going to call CYF on me? Is someone going to report me? And studies have also shown that for some of these groups, we should maybe be using a lower cutoff score
Mm-hmm.
for them, for various reasons. And we're not doing that. We're still using like 13, or is there suicidal ideation? So there are a multitude of issues. So if they know that they're not going to get services on the other end because of who they are, then, they are less likely to show up. They are less likely to engage, but they also know that engagement isn't happening on the other end. So we really have to make concerted efforts to reach out to these populations. So in our clinic, we did have an event recently. We partnered with an organization called First Steps and Beyond, which is to help decrease maternal and infant mortality in the Black community in Pittsburgh. We did an event with them to target Black moms in the fourth trimester. We are also starting a mother of color group called Mother to Mother, where we can have these moms come because sometimes they don't feel safe in spaces where they're the only ones who look like themselves.
Right.
So it's really important to create communities where we can talk about this in safe spaces so that, we can kind of get rid of a lot of that stigma and also make people feel safe. And like, yes, there is medical racism. We are going to actively work against the bias that exists.
Mm-hmm.
And we are going to work towards helping to decrease and eliminate these disparities.
Oh, yeah, and there's so much overhauling that needs to happen. And I mean, as you were both talking about, there's so many complex factors, multiple factors, that can impact somebody through their reproductive journey, well, their life for sure. But since we're talking about the reproductive journey, that are biological, cultural, social, you name it. It sounds like there are um, so many different ways that people can be experiencing, or reasons that people can experiencing this, um, that they themselves wouldn't be able to pinpoint. Oh, it's because I experienced this, or it's because I have these genetics. They're just feeling horrible, um, and they need help. So how can I ask you, Dr. Sackey, how are you reaching out? Like, what is that? How do you do that?
Yeah. Again, through education and having events like we did, but also in terms of when we've also been going out into the community and saying, like, let's have a table at this event. We went to an event where it was put on by a group of doulas, and specifically for Black moms. And we said, how can we give our information to people so that they can come in and know, oh, AHN is there doing something? And they were like, we didn't know that there were Black doctors there, because a lot of times people want to know that there's someone who looks like them,
Mm-hmm.
who gets what they're going through.
Mm-hmm.
And so we had at least 5 people who were at this event come and get our services, like call the next week for our
Oh,
services.
fantastic.
And so really going out to the community, like, we have to find new and novel ways to reach people. So podcasts such as this, going to community events, social media, go to where people
Mm-hmm.
are, because we know that in order to fix these things, it's not going to be the traditional structure of medicine that
Mm-hmm.
we've always used, because we know it's very hierarchical and it can have a lot of bias as well.
Sure, sure. So, in terms of screening, you have both mentioned screening. So, Dr. Dalthorp, what is screening? Like, what if somebody were to be screened? What would they experience, and what should happen after a screening?
So when we think about screening for PMADs, we think about in the OB office. And I think that it's getting better. There's more universal screening happening, but I think there had been a resistance to this in the past, really, because what do I do if I have a mom in my office and I'm an OB and she tells me she's depressed? She tells me that she's suicidal. and I can't get her in to see someone in mental health for 6 weeks,
Mm.
right? And so I think that part of the resistance to screening was that, what do we do with this patient? I actually have a nurse practitioner in my community who had a patient. She works in an OB office who was suicidal. And she took her to the emergency room, and there was no one there that could provide a one-on-one with the patient. So she literally had to stay in the ER with the patient for 8 hours.
Mm.
And so that's one way that you're never going to get someone asking again, when that's how they're, rewarded for doing the right thing to make sure that that mom was safe. And so I think that it's getting better. We need to be kind of creative in terms of how we support OBs and our colleagues in those clinics to take care of their moms. I think education screening that happens at a regular interval during pregnancy. I think, right around the time that the glucose tolerance is happening, we need to make sure we're screening then so we can educate and really make sure moms know what to expect in the postpartum period. It's ironic that, gestational diabetes, we do such a great job screening for it, but the mental health disorders that our patients are experiencing are more common even than gestational diabetes. So we've got work to do. I think it's getting better. You can use the EPDS, but a PHQ-9 will work as well. And I think something that is the next step after we get universal screening set up is going to be to really think about risk factors. So Dr. Sackey mentioned that there are a lot of things that increase risk for a mom to have PPD or a postpartum anxiety disorder, OCD, postpartum psychosis, whatever it may be. So doing a risk factor analysis in addition to screening, it's not just a number on a piece of paper. You're thinking about this mom's history. Does she have a history of trauma? What is her support system like? Really understanding her personal history of depression, if she has one, what medications she was on. I think we just have to dig in and really take better care of moms and do a more comprehensive assessment. And I know that's hard in the OB office. There are ways that we can integrate mental health into OB care. I think that's probably the best way to do this. Moms are comfortable in that office. They have a relationship with their OB, but the OB needs help to handle these mental health disorders in that office. I think, understanding that untreated mental illness is a harm. And so thinking about risk assessment is so important when you're talking to moms about mental illness and options for treatment. I think that there's a lack of awareness of the impact of untreated or undertreated mental illness in this population. And it's not just mental health, it's physical health complications. And so I think as we develop a greater understanding of these things, and even OBs are seeing, hey, my patients are going to have better birth outcomes. Their babies are going to be born at term. There's going to be less preeclampsia. And our pediatrician colleagues are going to see, like Dr. Sackey said, that these patients or these children that are coming up in their clinics, if their moms had less stress during pregnancy, if they were not depressed, they're going to have better emotional connections with them, cognitively, developmentally, they're going to be better. So it's something that it's really the whole healthcare system that needs to do better. And I love Dr. Sackey's approach of really getting out into the community to educate. That's amazing as well. Lots of work to do.
Right, right. I mean, if you really think about it, it does feel overwhelming. It does feel overwhelming to all the changes in the system that that need to happen. And I think all around, I personally, from most of the stories I've heard, physicians aren't supported well enough to be able to do even what they want to do to be able to help people. So the system is also in some ways failing the physicians to be able to provide the best care possible, because there's all these time constraints and all the stuff that just really doesn't fit. Maybe it fits for some things, routine outpatient stuff, but not for this, not this really complex um, stuff, these conditions, I should say, that need a closer look, as you were saying. So once, Dr. Dalthorp, you were saying you were talking a little bit about understanding the risks, and previously you had mentioned that giving people some information about the science is what's helpful. So once you have of those things, you're able to tell people those things. How do you start like treatment planning?
So a lot of it depends on severity. And so for some moms, if they have mild illness, if they are pregnant and they are concerned about taking medications, they should definitely engage in psychotherapy. That's going to be essential for every mom that's pregnant or postpartum. I think it's helpful, and telehealth just makes that so much easier. So you can imagine, before telehealth was as readily available, you have to pack up the baby or get childcare. So I really think that there's increasing options for moms to get psychotherapy that's really convenient. So that's absolutely first step. But I think if a mom has moderate to severe depression, I think we wait sometimes too long to get them started on treatment. We now have an FDA-approved medication, an oral antidepressant called Zurzuvae, that is available, and it's such a novel treatment. It's really a game changer for these women. And you may have an OB that would prescribe an SSRI, and they have some experience with that. Maybe it's helpful. And if a mom has had that medication before and it's been effective, great. But if you have a mom that is really depressed and it's postpartum and she's, say, 3 weeks postpartum, you really don't want to try a medication and do step therapy if there is an FDA approved medication. So I think one of the things that is so important is that we get moms better fast. And since we now have an FDA approved medicine that is a rapid acting antidepressant, and I've treated patients with it, and it really is a difference maker. I think making sure that that is available, that our OB colleagues know how to prescribe that, and then it's offered to patients. I think patients, for the most part, aren't aware that there's a medicine that they can take for 2 weeks and that can not only bring them out of their depression potentially and also help their anxiety, but protect them from the effects of stress. There's this stress resilience property that this medication can give moms. And so it's so exciting, and it's discouraging to me as a psychiatrist to see that we aren't getting more moms treated with it.
That's fantastic. I mean, it is, yeah, great. The more options, the better. I want to take just a quick step back to give a little bit more context to, let's just say, like postpartum depression and the life of it. Dr. Sackey, can you speak to like how would, first of all, somebody know if it's just like early postpartum, they're experiencing some baby blues versus they're having depression, postpartum depression, or when it's more in a more severe range. How would people gauge that?
Yeah. So there are a few things that I look at. I look at severity, their level of functionality, and then duration. So I think the research says about 60 to 85% of people experience baby blues. So it's like a normal adjustment and transition to whether it's becoming a mom for the first time or for the fourth time. There's still an adjustment period because you're becoming a mom of one or a mom of four. So that's a normal adjustment where you might feel some like tearfulness with baby blues. You might feel some low moods from time to time. You might feel some irritability because there are changes in sleep and there might be changes in appetite, but you're still functional. You're still able to care for yourself and your baby. Postpartum depression, and that lasts for maybe about 2 to 4 weeks postpartum, and the height of symptoms for baby blues tends to be about 3 to 4 days after giving birth. On the other hand, postpartum depression, it lasts longer, 2 to 4 weeks. If you're still having those symptoms and they're more severe, then you're like, this is probably postpartum depression. And again, I think it's important we talk about risk factors because you are at greater risk if someone in your family, your mom, your sister, your aunt has had postpartum depression. You've had postpartum depression before. You have a history of depression or anxiety. You have a history of trauma, especially sexual trauma. You are of a lower socioeconomic status. You are a woman of color. You've experienced birth trauma. You have a baby who is in the NICU. So those make you at greater risk for experiencing postpartum depression. And again, those symptoms last longer. They're more severe in terms of your mood is very, very low. You are not functioning very well. You are very isolative. You have basically a lot of the symptoms of major depressive disorder, but they're happening either during the perinatal period or postpartum period.
So, right, somebody who's experiencing baby blues, we're not thinking about medication, although therapy can be helpful for anybody at any time. As an option, that would be fine. But medication isn't really something to be considered. I'm thinking about what Dr. Dalthorp was discussing in terms of treatment planning. So, Dr. Sackey, at what point would you consider medication or help somebody consider medication as an option for treatment?
I think it's a case by case basis. So if it's their first time kind of experiencing these symptoms, I might wait the first week to 2 weeks kind of and see them a little more regularly. So I'll see this patient maybe weekly to see how they're doing. If it's someone who's experienced depression before or postpartum depression before and they're already on a medication, I'm probably more likely to be a little more proactive with the medications and to say, okay, you might be 1 week postpartum. Let's go up on your medication. And let's also discuss other options. For example, as Dr. Dalthorp was saying, zuranolone. I'll start to introduce people to it because they're going to have to probably prepare to take this medication. It's a wonderful medication, and a thing that also happens with it is it helps to protect people's sleep because their community around them really has to help out with childcare at night. And a recent article came out earlier this month about how people probably need about 4 to 5 hours of sleep in the postpartum period, and that helps to prevent and treat postpartum depression. So,
Continuous, not
yeah,
not the fun
continuous,
broken
not
sleep.
just exactly. And so I think one of the ways that zuranolone really helps is it helps to protect people's sleep because the community around is really helping with childcare. So how do we then prepare for that medication and like talk about the different things, but also, as we were saying, how do we prepare for therapy and not just maybe individual therapy, but does this person need a higher level of care if their level of depression is significant? And again, we don't want to wait for it to be really bad. We want to say, let's be preventative and do treatment at the same time. So we are very lucky at AHN to have a mother-baby IOP. So it is a program that's 3 days a week, Monday, Tuesday, Thursday for 3 hours, and it's group therapy. And it's all of the evidence-based therapies that are known to help postpartum depression. Interpersonal therapy, dialectical behavioral therapy, cognitive behavioral therapy, and behavioral activation, in addition to mom-baby yoga, some infant massage, and other different activities that come in from the community to talk to moms. So if someone is struggling, we'll say, let's have you come to our intensive outpatient program. And it really helps to normalize for a lot of moms. I'm not going through this alone. Other people are experiencing this. So I think it's really important to kind of intervene early, as Dr. Dalthorp was saying, like get in there early, start treating early, because we know the impacts of not treating early can be huge.
So, based on your experience of seeing that there had been impacts, there are impacts on kids of moms who had untreated perinatal mental health conditions, what do you see as the generational impacts for untreated?
I see them as being very large. So starting immediately, if a mom's experiencing postpartum depression, there's difficulty with bonding and attachment. And that can then lead to, physical and mental health issues for infant and for children growing up. So moms who have postpartum depression, their infants are more likely to have to go see their pediatricians. They're more likely to have medical problems, whether it's colic or digestive issues. They're more likely to have injuries. There's more likely to be, unfortunately, maltreatment or child abuse. And so those things impact mom-baby bonding. For infants whose moms have postpartum depression, there are issues with cognitive development, speech development. There are delays in, movement. Also, there can be issues with increased risks for ADHD, anxiety, conduct disorders, depression. So we just see how this impacts multiple generations. And so it's really important to target it very early.
Dr. Dalthorp, why are those impacts happening? If I can maybe ask it in a different way, what is creating the impacts on kids when moms are untreated?
Yes, I think it can start during pregnancy. I know I read a study recently about acute stress in the third trimester being one of the most harmful events as opposed to chronic stress throughout the pregnancy. But what we know is that the baby's brain is developing, in the womb during pregnancy, and that mom's stress hormones and her, emotional response are mood, all of these things are transmitted, through the placenta, her hormones and those stress hormones to the baby. And I think that we underestimate that connection.
Mhm.
In the postpartum period, as Dr. Sackey said, this bonding is a huge issue. And what is happening is the baby during those early days and weeks and year, the brain is developing, and parts of the brain that are involved in emotional regulation are developing. So thinking about the amygdala, the emotional memory center in the brain, we don't think of a newborn as having emotions, but that system, that circuit, that neurocircuit in the brain is responding and is kind of shaped during early life experiences. And so when you take a mom that has depression or anxiety or mental illness, likely she has maybe a genetic component. We know that in hormone related mood disorders, it's highly genetic, and moms have brains that are sensitive to these hormonal fluctuations. But those risks are typically kind of sent down, right? Her children are going to have a genetic risk, but what really does it is there's epigenetic changes. And so when you put someone that has a genetic risk for mental illness into an environment that turns on genes, then you really have this double whammy where you're dramatically increasing the risk of a child developing mental illness themselves, of developmental issues. It really compounds, and in that way, it's generational. And so, if you can take, you see PPD running in families, and if you can take a mom out of her depression and minimize that generational impact as much as you can by treating her depression, I think it's amazing, right? It's helping future generations as well. So I think it's an area that we're learning more and more about, stress response and how trauma and these things can turn genes on. But I think it just really sends the message home that there's a risk of not treating, that we need to aggressively treat to help minimize the risk that we're going to see.
Sure. Thank you for that. And we know we're primarily talking about postpartum depression, but we've also alluded to there are many other things that can be happening. What do you most commonly see as comorbid or coming along with a postpartum depression?
Anxiety is really common in the perinatal period. I think 20% of women are going to have one or more anxiety disorders during the perinatal period, and it commonly goes along with depression. I think one of the most difficult things that I've seen in patients and treated is kind of a very intense form of anxiety. It's a perinatal OCD or a postpartum OCD. I've actually had a husband call me when I was in practice a couple of years ago, asking me to get his wife out of the inpatient unit. She wasn't my patient, but he had taken her to the emergency room because she said, "I'm afraid I'm going to hurt my baby." And in the ER, this kind of goes back to educating all of our healthcare practitioners about PMADs. They heard her say, "hurt my baby," and they assumed that she had postpartum psychosis, which is, of course, an emergency, and an inpatient is warranted. But if you really dig in and ask the mom what she's experiencing, you're going to find that she doesn't want to hurt her baby, that she's not psychotic, that she's not going on 2 hours of sleep. She doesn't have a history of bipolar depression. There are things that it's a very different presentation. She doesn't want to hurt her baby. She's just afraid. So it's anxiety on overdrive.
Mhm.
So that's something that we do see in the postpartum period, and it's really, really difficult. Sometimes moms are afraid to admit that they're struggling with this because the intrusive thoughts might even be the worst thing they could ever imagine happening to their baby.
Mhm.
And it just builds and builds. And sometimes they don't get help, which is really, really sad. But there are treatments that are effective. I had a patient who was afraid that she was going to stab her baby, and she went through a therapy called exposure and response prevention therapy. You have to have a skilled therapist who understands how to do this. And she went through therapy. She held her baby and a knife, and she was able to overcome those intrusive thoughts. And fortunately, she didn't have those same symptoms with her next pregnancy. But I think that's one that's really devastating, so I bring it up. But generalized anxiety disorder, phobias, PTSD, women are more likely to develop PTSD than men. And gosh, there's so many women that have birth trauma. And so I think that, I hope someday we will have an environment where moms are treated differently during childbirth. It's just
Mhm.
so medical, not, it's like a medical thing, and there's not a lot of support. So I think one of you mentioned doulas. I think that there's a lot of support that we need to provide moms to make
Mhm.
that experience less traumatic. That's gonna impact mom and baby going forward as well.
Right. Dr. Saki, so for people who maybe are just learning about this or just listening to this, it sounds hard and maybe even bleak, and overwhelming if you're just finding out about this and some of the things we've discussed today. So what's the kind of good news? How What can you say to people who are concerned about postpartum depression, postpartum anxiety? What are the things that we can do to make sure people are well and stay well?
It's a great question. So I think we let them know that because postpartum anxiety and depression, these things aren't caused by one thing, they're caused by many things.
Hmm.
So our treatment has to be multidimensional as well. We have to
Hmm.
have pronged approaches to it. So again, medications, talking to them about the risks of taking meds versus the risks of not taking meds
Hmm.
versus the risks of being unmedicated with this disorder, having those conversations and making sure that they're continuous conversations. And I tell my patients, I prescribe you meds so that you can engage in therapy because I think
Hmm.
therapy is where you're going to get the majority of your work done.
Hmm.
Also, you see your therapist a lot more regularly sometimes.
Hmm.
Um, I also tell my patients, meds are for as long as you need them. So sometimes people are like, I'm going to have to be on this medication forever. There's
Right,
something wrong with me.
right.
Your doctor should be prescribing meds ideally at the lowest effective dose for as long as you need it. It's kind of like if it's someone once told me if it's raining, you turn your windshield wiper on. If it's raining really heavy, you turn it on at a very high pace.
Hmm.
But when it stops raining, you can turn the windshield wiper speed down,
Hmm.
potentially up.
Hmm.
So we can approach medications the same way. There are some people who do need medications for a longer period of time, and that's really
Hmm.
based on different factors potentially in your history or your diagnosis or your symptoms. So medications are very helpful. There's therapy for this.
Hmm.
There are many different types of therapies that are targeting different symptoms, different diagnoses. We can engage in those therapies. There are other resources as well. So whether it's group therapy like IOP,
Hmm.
higher levels of care, there are PHPs. Some places are very lucky to also have inpatient units for severe symptoms. But hopefully we can help to spread and get more of those around the country. We also know that there are wonderful support groups that are out there.
Right.
Um, there's Postpartum Support International that has a myriad of support groups
Hmm.
for different people of different identities or with different diagnoses. We also know that there are a lot of specific organizations that help out as well, such as like Black Mamas Alliance. And there are many different ones as well that can help people. And Google has so many things that you can find, but hopefully providers are really giving these resources to patients, or providers are hopefully researching for patients these
Hmm.
things because sometimes it can be really overwhelming. And so I think when you can provide patients with that information, it helps to streamline where they can go.
Right. And you see, I mean, we're kind of in the business of holding hope for people until they can have it for themselves in some way. Um, do you see people getting better?
Yeah, absolutely. And I think one of the good things too about group treatment is you'll have a mom who it's her first day versus a mom where she's been in the program for maybe 2 to 3 months and she's graduating. And during graduation, we have a rock that's passed around. And again, holding hope, and everyone kind of just says to the mom, like, what they admire about her, words of wisdom or words to carry forward. And that's really, I think, that provides hope for a mom whose first day it is in the program of, will I get better? Here you
Hmm.
are seeing someone who got better through community, through her support system, through working with providers. And so again, using all of these different approaches, I think it really shows people that there is hope. You can get better. You can get through this.
Great. And Dr. Dalthorp, what do you see in terms of, people recovering and getting back to their lives?
Well, I just want to say peer support is amazing. Group therapy is amazing. And I think when a woman has their own experience and they feel comfortable enough sharing with other women, I think that having been there, that's one of the most important things, that those
Mhm.
messages that they can share, that shared experience is so impactful for these women. Um, I mentioned zuranolone a little bit ago, but I think that it is a really exciting medication that we should be thinking about. If a mom, I think it's 67% of women who have PPD either had depression before pregnancy or they have depression that develops in the third trimester. So most women, we have a heads up. We know that this postpartum period is likely going to be destabilizing, and we can educate and prepare them. It doesn't mean that you have to immediately put them on a medication, but because the medication, you need a prior authorization, which we haven't had any issues getting it authorized since it's the only FDA-approved medicine. But just getting the mom thinking about that ahead of time so that if you need it, you've already had that discussion, and you're prepared so that we don't have a delay in taking, getting that mom to treatment. There are other, of course, antidepressants that we can use. And like I said, if a mom has had a previous experience with an SSRI that was helpful, and if she has mild depression and she's engaging in therapy, I think that's very reasonable. But for those that are really struggling, I think taking a little bit more aggressive action is necessary to minimize harm.
So, Dr. Sackey, and I'll ask you both the same question. Dr. Sackey, what do you hope that people take away from our conversation today?
Great question. I hope that they take away that postpartum depression is common. A lot of people experience it. It is treatable, and there is support out there for you. And we want to help you so that you can be the mom that you want to be, that you can engage with your baby and your family in ways that you want to, and you can get back to being yourself. And while it might feel hard, please ask for help. Sometimes when we're not able to speak up for ourselves, we can use our community to do that. So whether it's your spouse, your sister, your mom, because sometimes, doctors, they don't do right by patients. And so really advocating for yourself and asking about things, asking about medications, about therapies, um, really engaging and almost being a pest in a way, because you and your community can be your best advocate so that you can treat yourself, and work with your provider to help treat you as well. So please ask questions, please get information,
Mhm.
please support, and hopefully there are people on the other end there to help you.
Great. Dr. Dalthorp, how about you?
Yeah, I'll echo what Dr. Saki said. There is effective treatment. And I think, we can never tell a mom that she needs to choose between herself and her baby. What's best for baby is mom getting treatment and getting better. Absolutely. That is what's best for baby. I think another misconception might be that you have to be pregnant, have a baby, and take the baby home to have PPD. But if you have been pregnant and you're not pregnant, you are postpartum. And so patients who lose their baby during pregnancy, or those who have a miscarriage or have a failed infertility treatment, those are very traumatic, very stressful, emotionally complicated events. And medications treatment is necessary and can help those women as well. I know that we've treated quite a few patients who have unfortunately lost their child during pregnancy, and they need help maybe more than some of the other moms. It's such a devastating loss. And so not just a mom that takes a baby home that has the stress from caretaking, but any woman who's had a pregnancy and is no longer pregnant that experiences depression, has postpartum depression and needs treatment.
Great. Well, I thank you both so much for coming on and educating everyone. It is so very important to get this information out there, and the work that you're both doing and the advocating and getting the message out there is incredibly important. I know somebody will be helped because of this today. So thank you so much for being here.
Thank
Thank you.
you.
Thanks for all you do and for having us too. And nice to meet you, Dr. Saki.
Likewise, yes, thank you both for the work that you do.
You can find Dr. Rachel Dalthorp at reproductivepsychiatry.com and Dr. Sackey at ahn.org. Thank you so much to both of them for joining in on this important and needed conversation. And I really, really, really appreciate having multiple perspectives on all of the things we talk about on this podcast, but it always brings such richness when we have two guests on at the same time. And for you listening out there, make sure you have followed and subscribed to the Mom and Mind podcast wherever you listen. And do make sure to also submit a review so that other people can know how you find this podcast beneficial. Thank you so much for joining me. Until next time.